The I have a pleasure in inviting Dr. Lalit, Dr. Amit, and Dr. Prashant Bhandarkar, who has informed me that he will be joining little late. So we start the proceedings and hand over the mic to the chairpersons and Saurabh.
Good evening, everyone. Thank you, Mukevar sir, Midas Medical Foundation, MSN, and all the chairpersons for this excellent opportunity to allow me to talk on this topic. I'm going to talk on preference of biological in a patient who has never received biologicals before, that is bio-naive patient. This is the obligatory figure of what we have in our biological arsenal. The age-old TNF antagonists, infliximab, adalimumab, certolizumab, and golimumab. The not so new vedolizumab and etrolizumab, which are alpha 4 beta 7 integrins, and IL 23, IL 12 antagonists, ustekinumab. As we all know that the route of administration is IV for infliximab, vedolizumab, and for the loading dose of ustekinumab, we have IV, as the maintenance dose is subcutaneous, and adalimumab and certolizumab are subcutaneous. The source of our understanding regarding this topic is very blurry, I would say, rather, because there is a lack of head-to-head studies of the different molecules. Most of the evidence of safety and efficacy is from the clinical trials, which are comparing these biologics to placebo, not the head-to-head trials. There is a high variability of individual factors like genetics, age, sex, and how the patients will behave to the metabolism rate of the biologicals in these patients. Then there is some interesting effect called as warehousing effect in studies. That is, we as clinicians, we tend to pile up our patients who are not doing well, who are difficult to treat, and subject them to the newer molecules. So that is not really right to subject them to such difficult to treat patients for newer molecules, because then the data will be biased. So the main source of our understanding is network meta-analysis of biologics and the real-world studies or real-world experiences, what we have. So briefly, I would state the indications for starting biological therapy in bio-naive patients is the patients with extensive disease or other poor prognostic markers, individuals with illness which is resistant to immunomodulator therapy despite of higher doses, young patients with severe disease, which we are now following a step-down approach, visualizing Crohn's, and in avoiding post-surgical recurrence, especially in patients with Crohn's disease. So this is the line of my talk. These are the subtopics. Choice of biologic in bio-naive patients. I'll be discussing under four subtopics. That is moderate to severe luminal Crohn's, visualizing Crohn's, moderate to severe ulcerative colitis, and acute severe ulcerative colitis, as well as the other factors which are to be considered while considering biologicals in a naive patient, and summarizing it in 2 slides later on. So I'm going to be babbling a lot of numbers. I'll try to summarize each subtopic so that we'll have a line of what I'm talking about. The CView trial in recently in 2021, which was in 386 biologically naive patients with luminal Crohn's, ustekinumab versus adalimumab was studied, and there was a comparative 65 and 61% remission at 52 weeks, suggesting equivalent effect of both the drugs. In 2016, Cosnes et al. In 906 biologically naive patient, adalimumab versus infliximab, suggested that there is a good response rate at 6 months and 2 years follow-up, and both of the molecules had similar efficacy, and combination therapy with immunomodulators was supposed to be better as compared to individual molecules. Singh et al. In 2017, again 827 biologically naive patients, adalimumab versus infliximab. Over 2 years, there were no significant difference in the disease-related hospitalization and major abdominal surgery or serious infections. So both the molecules are comparable in terms of effectiveness as well as safety. Narula et al. In 2016, again the same molecules, adalimumab and infliximab, in 362 biological naive patients at a shorter duration of 12 weeks as well as a longer duration of 52 weeks. Steroid-free remission was comparable in both the molecules. So as we can see, most of the studies where head-to-head trials are done, the two molecules are adalimumab and infliximab. There is a lack of studies which are comparing the other molecules like ustekinumab or vedolizumab along with anti-TNFs to have specific data. Other RCTs which are going on are these, and we will be having the results within a year or so. So, as I said earlier, we rely on systematic review and network analysis. So, this is a good one which was published in October 2021, meta-analysis of 31 phase 2 and phase 3 RCTs, which included moderate to severe Crohn's disease of around 3,000 biologic naive patients. So, the remission data in these naive patients was combination therapy of infliximab with azathioprine was the best with the odds ratio of 7.5, followed by infliximab alone, followed by vedolizumab, adalimumab, and ustekinumab. All these were more effective than certolizumab pegol. So to summarize this subtopic of moderate to severe luminal Crohn's, I would say infliximab and adalimumab are the most used biological drugs and appear to have similar effectiveness as well as safety profile. The approval of vedolizumab and ustekinumab for Crohn's has expanded the therapeutic arsenal in this regard, and there is little evidence comparing anti-TNFs with Vido or ustekinumab in naive to biological Crohn's patients. But the data which we have from real-world experience to date, it seems to be really appealing, and there is some comparable effectiveness in this indication. Second subtopic which we would be talking about is fistulizing Crohn's. As we all agree, it is a very difficult to treat disease. It often requires medical as well as surgical management. And unfortunately, the data we have is from subgroup analysis of other meta-analysis and extrapolation from small observational studies. Also, most of these fistulizing disease which are included in the study are perianal, not the enteroenteric or enterovesical fistulae, internal fistulae. So it was a eureka moment for Rudgitz in 1999 when Rudgit et al. Saw that infliximab achieved complete fistula closure in all of the 94 patients, which was obviously perianal. In Accent 2 trial in 2004, we have a good data of infliximab who achieved induction with infliximab. Their maintenance at 54 weeks was also found to be very good. CHARM RCT subgroup analysis showed superiority of adalimumab over placebo in 7 patients with perianal Crohn's. Because it is subgroup analysis, the data is not really strong, has lower power. Gemini trial in 2013, 165 patients with at least one fistula. Vidos versus placebo, Vidos was found to be better. In recent data by Schwartz et al. In 2021, there's a phase 4 data which has compared 2 regimens of vedolizumab, wherein the first regimen is standard one, second regimen they have included one more dose at the 10 week. They said that more than 50% reduction in at least half of the number of fistulae draining perianal was found with no differences between the 2 doses. So there is a good response to vedolizumab as well. IMUnity trial in 2012 showed that ustekinumab induction versus placebo ustekinumab was more effective. Similarly, the data by Sands et al. In 2017. But the strongest evidence and hence the choice in fistulizing Crohn's is still infliximab. Coming to moderate to severe ulcerative colitis patient, the very well-structured Veracity trial of Vedos versus adalimumab in a 771 biologically naive patients. At 52 weeks, the clinical remission and endoscopic improvement was superior in the vedolizumab group as compared to adalimumab. Now in 2021, we have the new data is coming up for histologic remission, which is again better with vedolizumab. And post-hoc analysis has showed mucosal healing is also better. That is 25 versus 6% in vedolizumab as compared to adalimumab. So Vedos is better. Singh et al. In 2017 comparing adalimumab and infliximab in 1700 biologically naive patients showed that adalimumab can be used as a first-line biologic over infliximab, but it was associated with higher risk of adverse event and hospitalization. So the safety profile was not favorable for adalimumab here. Bresler et al. In Evolve Study 2021, again, Vedos versus other anti-TNFs. The clinical response was found to be better with vedolizumab, or they were at least equally effective with the other anti-TNF treatments. But vedolizumab had a more safety profile because of less chances of infection, cancers, and serious adverse events. Patel et al. 2 years back, comparing vedolizumab and infliximab in 1700 patients, showed that persistence of remission was higher for vedolizumab as compared to infliximab. Then again, we come back to network meta-analysis, 12 trials, none of which are unfortunately head-to-head comparisons in biologic naive patients. The SUCRA values, that is surface under the cumulative remission curve, the higher the value, better is the molecule. So infliximab and vedolizumab are the scorers here clearly. Infliximab was superior in inducing clinical remission as compared to adalimumab, and there were no difference when it was compared with vedolizumab. So in terms of safety, as again, vedolizumab is a safer molecule. Other trials which are recent one, 2021, a Japanese study which stated that highest rate of remission was by infliximab and vedolizumab. Another one in 2018, which also showed that best for remission are infliximab and vedolizumab, followed by golimumab. The AGA guidelines also suggest that when there is an indication for biologic therapy, it recommends anti-TNFs in bio-naive UC patients, but also suggests that vedolizumab and even tofacitinib could be used as a first-line therapy, particularly in special populations. So to sum up, moderately severe UC, still infliximab and vedolizumab are the drugs of choices. Acute severe UC, there is one word, that is infliximab. In 2005, there was this study by Gunnar et al. Which showed that 45 patients with acute or moderately severe UC, which was refractory to IV steroids, the rate of colectomy were very low amongst those patients who received at least one dose of infliximab as compared with placebo. Other option, if you do not have to give infliximab in acute severe UC, is induction with calcineurin inhibitors. But the maintenance again is going to be with biologicals, which is preferably infliximab in these patients. So for acute severe UC, the only option of choice in bio-naive patients is infliximab. The struggle does not just end here. We have so many other factors to be taken care of. I'll just touch briefly each of them. Genetic factors, as we know that there are so many single nuclear polymorphism that we are still unaware of, that may be affecting the metabolism of biologicals in these patients. So many genes have been evaluated, especially related to TNF agents, but the overall response and results are very poor, and there is no good predictive factor for anti-TNF response. There was this prospective multi-center cohort 2 years back in patients of luminal Crohn's disease with anti-TNF treatment, and they judged what are the failure factors. So the only factor which was associated with primary non-response to anti-TNF was low drug concentration at week 14, which was partially at least thought to be because of immunogenicity, that is formation of antibodies against the anti-TNF agents. This can be ameliorated by adding of azathioprine or other immunomodulators. Specifically in European population, as we know, HLA-DQ1 variant, they have a higher risk of developing antibodies against infliximab and adalimumab, regardless of the concomitant immunomodulators. But this data cannot be extrapolated to Indian population because of the genetic differences. Regarding sex, there was suggested in a study that anti-TNFs may be cleared faster in men than in women, but this was not seen in other studies, and there still is not enough evidence to follow this. This is interesting regarding the age. Advanced age is a risk factor for other comorbidities, as we know, that is cardiovascular disease, diabetes, cancers. So these patients are different in terms of metabolism of like absorption, distribution, excretion of drugs, including the biologicals. So there is often a mismatch between the chronological and biological age. You may be having an 80-year-old who can run 2 miles a day, or a 65-year-old who is very frail and is bedridden. So the drug will not perform equally in both these patients. Adverse events are also more frequent in the elderly population, namely infections, and they may be developing cancer further. The ECO guidelines recommend anti-TNF monotherapy over combination therapy in elderly patients because of this fear of serious adverse events. So vedolizumab and ustekinumab, who have a better safety profile, may be prioritized in these patients, which was also suggested by subgroup analysis in Gemini and IMmunity trials. Inflammatory markers, albumin and CRP, they are not really good predictors. It has been seen in studies, but there are few studies which are supporting the use of these inflammatory markers to judge regarding getting biologicals in these patients or not. But the data is not really clear. Comorbidities, yes, at least 2-3 things are very important, which I have mentioned here. In rheumatology, they have seen that they are also using obviously the biological drugs. They are seeing that the patient who have obesity, they are worst responders because of increased volume of distribution, so leading to low drug concentration. Secondly, they may have been having higher systemic inflammatory burden due to obesity-induced low-grade inflammation. Again, these anti-TNF agents are to be used very cautiously or avoided in patients with congestive heart failure, specifically avoided in NYHA class 3 and 4. And it is not appropriate for the patients with demyelinating disease like optic neuritis or multiple sclerosis. Again, ustekinumab or vedolizumab may be prioritized in this special population with these comorbidities. Extraintestinal manifestations, we know that polyarthritis and axial arthropathy, the IBD activity is independent of articular inflammation. But in peripheral monoarthritic activity, the disease, the IBD activity is associated with articular inflammation. So in these class of patient with arthropathy, there is good evidence with anti-TNFs. Infliximab and adalimumab can be used for Crohn's and UC as well, but golimumab is effective only in ulcerative colitis. The dose should be, if there is concurrent arthritis as well as IBD activity, the dose which should be used is that is for IBD, which is a higher dose. If there is IBD without any active arthropathy, then, I wrote it wrong. If there is active arthropathy without any IBD, then you should prove remission by endoscopic means or imaging or inflammatory markers, and then give rheumatologic dose for the patients with these active arthropathy who do not have IBD activity. If any immunomodulator is to be added, obviously methotrexate will be the choice because it has good action against the arthropathy. Ocular manifestation, the one hand winner is adalimumab. It has got great evidence in ocular manifestations with IBD. Skin manifestations, the commonly seen are erythema nodosum and pyoderma gangrenosum. Anti-TNFs are the preferred choice here. In IBD with psoriasis, anti-TNFs as well as ustekinumab are helpful. But sometimes it was seen that with anti-TNFs, a paradoxical exacerbation of psoriasis occurs. In these patients, ustekinumab can be used as a rescue therapy. Again, there are patient preferences. Subcutaneous therapies could be preferred in patients who do not want to visit hospital again and again. Or for our good, if a patient who has lack of adherence, you want the patient to come back, better to put him on IV medication so that you can be seeing the patient regularly and is making sure that he is adhering to the treatment. Speed of onset is a very, very important factor, as we know that vedolizumab takes around 2 weeks, especially in bio-naive patients. But anti-TNF, especially infliximab, which has been used in acute severe UC, can be having effect of with a single dose within a few days. Cost effectiveness is a very important factor, especially countries like India. We have to also consider the cost, not on the drug, only the drug itself, but the need for hospitalization, IV injections, consultant visits, complementary exfoliations, surgeries, adverse event related costs. So all this adds up to the cost effectiveness of the molecule. For moderate to severe Crohn's disease in a US study in bio-naive patient, done in 2019, infliximab was still found as the most cost-effective biologic, followed by adalimumab and UST. We have to consider infliximab, the maintenance therapy is 8 weeks apart, while as in adalimumab, it has to be every 15 days, every fortnight. So the cost comparison changes there. And the availability of biosimilars has changed the scenario because almost equal efficacy can be gained at a very, very cheaper price. So to summarize my presentation, the indication for the choice of biologic for luminal moderate to severe Crohn's would be infliximab and adalimumab, whereas UST, that is ustekinumab and vedolizumab, also seem to be a good option. In fistulizing Crohn's, infliximab seems to be the best option, but adalimumab, ustekinumab and vedolizumab also seem useful. Acute severe UC, as we said, infliximab is the only drug of choice. In moderate to severe ulcerative colitis, infliximab and vedolizumab seem to be the best option. The real world experience for vedolizumab is gaining more popularity and may override infliximab over time. Golimumab and ustekinumab are also useful. Adalimumab in this context seem to be less effective. The HLA-DKA1 genetic polymorphism, the use of anti-TNF combination should be done with another immunomodulator, or simply other biologic like ustekinumab or vedolizumab should be tried in these patients. Elderly patients, because of fear of infections and serious adverse effect, ustekinumab and vedolizumab are the clear winner here. In arthropathy, UC, infliximab, adalimumab and golimumab. In Crohn's, infliximab and adalimumab. In eye-related like episcleritis or uveitis, anti-TNFs, specifically adalimumab. Skin manifestations, erythema nodosum and pyoderma gangrenosum, anti-TNFs are the choice. Psoriasis-associated, anti-TNF or ustekinumab. Patient's route of administration preference, subcutaneous. For UC, it should be golimumab, ustekinumab or adalimumab. For Crohn's, adalimumab and ustekinumab. For intravenous, clear choices, infliximab and vedolizumab. If the patient has low adherence, better to give the IV agents, and financially poor, low resources, anti-TNF biosimilars would be preferred in such cases. Thank you.
Questions and answers we will take at the end of the session. The second topic, which was to be presented by Dr. Pradeep Padale, will be postponed because he is busy somewhere in a procedure. Pratik. Okay, that's good. We can take 1 or 2 questions now also.
Actually, must compliment you for that exhaustive presentation. Till Pratik warms up, we can have a discussion only. Must compliment you. I have few comments. One, actually, there are hardly any head-to-head trials comparing one biologics with another.
Right.
So, the majority of the times, what data we have is network meta-analysis. For the people, those who should understand network meta-analysis, A is compared to B and B is compared to C. So network meta-analysis is comparing A with C on the results of comparison of B and C. So A is compared with B, B is compared with C. So they derive the results on the basis of comparison between these three. That is network analysis. Because these questions, these things will be very well more often quoted. What is network meta-analysis, and one should know about it. So I think the Versity trial was the first trial which compared adalimumab versus vedolizumab, and it has clearly shown superiority of vedolizumab in patients with moderate to severe ulcerative colitis. I have my concept about the biologic seeds. Infliximab is probably the strongest and the best in terms of clinical response, remission, patients with ulcerative colitis. Of course, in Crohn's disease, you already suggested whatever molecules are there. But I feel that infliximab probably is. The another thing is utsicumab. Utsicumab is the one, along with tofacitinib, is a drug which is of the best choice in biological experienced persons. So if you have a biological experienced person having moderate to severe disease, probably availability of, we don't have utsicumab, but the data suggest that utsicumab and tofacitinib are the better choices than the other drugs. I mean, because in one of the network meta-analysis, you quoted the efficiency of utsicumab much lower. But I personally have that perception, whatever this thing goes, that utsicumab is a very strong drug and with definite indication in biologics failure.
Sir, as you rightly said, in network meta-analysis, when we talk about it, is not of more of observational evidence. It is more of calculation of deriving things from certain variables. So, regarding ustekinumab and tofacitinib, yes, I agree to that point. But more stronger data is regarding the maintenance of remission is very, very good with ustekinumab as well as tofacitinib. That's what I've seen.
No questions. Shall we start the second session? The second session is by current concept of remission. So, mucosal healing, biochemical healing, endoscopic healing in patient of IBD by Pratik Padole.
Also, sir, rightly said that infliximab is a very stronger molecule in terms of clinical remission and efficacy. But now that we are recognizing the problems, we have main three problems. First is primary non-responders, which may be because of some genetic pleomorphism. Second is loss of response in these patients, which may be because of the immunogenicity, that is formation of antibodies. And third is the serious adverse events, specifically in specific population, elderlies, and with other comorbidities. So because of these three very important factors, now ustekinumab and vedolizumab, which are more gut selective, are having a greater chance. And at least in real world evidence, we have a greater value for it. So probably in more upcoming head-to-head trials, we'll have a stronger data for these two molecules over the anti-TNFs.
Yes. Good evening, everybody, and thank you so much, sir, for letting me stand before such an esteemed audience. And I apologize, I was stuck up in some emergencies. I was about to reach here, but I was stuck up. Thank you, sir. Thank you once again. Thank you, all the audience. Today, my talk would be more of an conceptual type. I have basically divided my talk of 10 to 15 minutes in two basic parts. The first part is very objective, which we go through internet, or we have many resources online that we calculate various scores, we apply it to our patients, and then we see for follow-ups. So the first part would be definitions of all the remissions, like the clinical remission, endoscopic or the mucosal healing, histologic remission, and later down molecular and biochemical. So this was the topic which was allotted, but I thought I should add one part to the talk as of the evolving concept of remission in IBD. So to start with, what is remission in IBD? Remission, the dictionary meaning is the diminution of the disease activity. So IBD, if the disease activity is increased stool frequency, bleeding per rectum, the original targets of treating IBD were like to decrease stool frequency, bleeding per rectum kam kar do, pain in Crohn's disease, or any obstructive events in Crohn's disease. So this was the primary target to start treatment for IBD long way back. And it was called as clinical remissions. And people were happy treating the disease clinically. But later down the line, over decades of experience studies, they found that clinical remission is not enough. So they started finding other targets to make the life of a patient of IBD better. So remission, then it was then applied to a broader concept. Later came down the clinical remissions was basically based on patient-related outcomes, and the components for, like I said, for the ulcerative colitis part was the stool frequency, the bleeding episodes or mucus passage, and the general well-being of the patient. And for the Crohn's disease, as we know, the CDAI score is generally used for the clinical part of Crohn's disease. So this constitutes the clinical remission. The advantages was it is very easy to monitor and apply and to reproduce. It is non-invasive and it is low cost. However, the disadvantages which was found on later studies was that it does not correlate with the disease activity down the line. So it's not reliable. It is discordant with the endoscopic changes. So which was shown later that the endoscopic changes were more concordant with the outcome of the disease. And the studies do not show any strong correlation with the long-term outcomes. So clinical remission had a setback, or it was stepped aside. And the study showed that, however, there was clinical remission in patients. Around 40 to 45% of these patients actually had endoscopic disease. And later down the line, this endoscopic disease progressed to produce complications of dysplasia and eventually invasive cancers. And also the quality of life was not concurrent with the clinical remission. So later came the concept of mucosal healing or endoscopic remission. This is also all online resources we have for ulcerative colitis. We have the Mayo endoscopic score, which we generally use, which all the societies have recommended as of now because it is the most tested and validated. However, the better score would be the UC endoscopic score, that is UC-EIS, and it has three components. It is the problem with UC-EIS, do better outcomes and do better concordance. It is not strongly validated as of now. So the current guidelines suggest you to use UCIS, but they do not recommend to use UCIS. All the studies currently are based on the Mayo endoscopic score. For the Crohn's disease, we have a simple Crohn's disease endoscopic score. Earlier it was an expanded version. They have abrogated it and made it into a smaller versions, and that can be used for the patients for follow-up. So this came in because the study showed that clinical remission was not enough and the endoscopic activity was persistent even if the patient was in clinical remission. And for endoscopic activity charting, we have all these scores, the Mayo scores, the UCEIS scores, the Crohn's disease scores. So the advantages here was it is very strongly study backed. It has a strong correlation with the long-term outcomes, and it has now become a component of what is now evolving is the strategy of treat to target, which we will discuss further down the line. The disadvantages in our country and also in other countries is the first disadvantage is it is invasive. It has to be done with an endoscopy. So the problem here lies is when the patient is clinically improving, he has clinical improvement, even then we need to monitor him endoscopically. So this has come into guidelines. पहले ऐसा नहीं था कि एंडोस्कोपी करने की जरूरत पड़ती थी, but now it has come into guidelines that every 6 months, according to the disease activity, every 6 months or 12 months, the patient needs to get an endoscopic surveillance for the endoscopic activity of the disease, which we'll discuss later. So in our country and Western countries also, the cost was a major issue. because in West it has to be borne by the insurance companies. Mostly in our country it has to be borne by the patient. So in a situation where the patient is clinically improving, to do an endoscopic surveillance is difficult. And validation, earlier it was a problem with endoscopic or mucosal healing, but now there are many studies which have shown extensive validation of endoscopic healing in concordance with the long-term outcomes. So as we discussed in ulcerative colitis, we have the Mayo score and the ulcerative endoscopic score. In the Crohn's disease, we have simple endoscopic scores and the Rutgers scores in the post-trauma patients. Then came the concept of deep remission. So as studies evolved, they found out that there could be certain biological markers which could be done minimally invasively, that is through blood, and could correlate or track the disease activity. So majority of these markers were CRP, in some cases ESR, and majorly fecal calprotectin, which has grown to be a very good stool marker for tracking the activity of the disease. And there are extensive studies which show that the disease activity actually correlates with the fecal calprotectin. It is now not generally used to diagnose a flare. However, it can be helped as a adjuvant marker to see the response of treatment to a flare, and also the possibility of relapse of the disease. So yes, so deep remission included clinical remission, that is the improvement of clinical symptoms, plus the mucosal healing part, which is done endoscopically, plus some of the markers. So for UC, it was a clinical remission, the clinical activity index of less than 4, and for CD, it was CDI less than 150. Endoscopic part, there was the absence of, that is Mayo's 0 or UCI 0, that is absence of friability, this is Mayo 1. Which is absence of friability. However, there could be minor erosions. So Mayo score 1 was taken as a part of remission. Similarly, for Crohn's disease, the absence of mucosal ulceration. And in the biologic component for the Crohn's disease, CRP is to be has been validated that a CRP of lower than 5 units was required to call it a remission. So we are reaching to a stage where we have included biological markers also to term the disease to being in remission or not. Then people tried कि इसमें ठीक है, we have clinical improvement, we have endoscopic improvement, there are biological markers which are going down. However, there were further studies which actually extensively studied the histopathology of the deceased part of the intestine, and then there are many scales used, but none of the scales is validated as of now. Histopathology to be included in remission is not recommended by any guidelines or by any society, but people think it is the way forward, that histopathological remission would also be included in the treatment targets of IBD. So one problem is that the scales are not validated. It is a very laborious procedure. It is a labor intensive and human resource intensive procedure. Of course, the cost is a matter. And yet there are no very long-term studies of a long-term correlation of the outcome of IBD with histopathologic remission changes. We have talked about the molecular remission. So the first part was, it's just the definitions of what all remissions people have been using up till now and what is in the basket to be used in further down the lines. Actually, these definitions are made by the societies to be used in clinical study scenario, wherein if a target drug is to be studied, the objective evidence of remission has to be defined under something, and currently we have evolving concepts of the same. So the approach to IBD remission, as I said, few decades back, it was clinical remission itself. Then people have studied biomarker remission, endoscopic remission, and now the histologic remission. And for Crohn's disease, the counterpart of histologic remission would be a transmural remission, which is accessed by cross-sectional imaging. So to start with, the remission was, this is a cartoon I got from Nature Reviews for the IBD remission. To start with, it started with patient-related outcomes, then came the endoscopic healing, and now we are approaching toward histological healing and molecular healing. So all these things came into light because people have now believed that IBD itself is not just a clinical disease. It has to be evaluated across all the fronts because it has long-term impacts on patients' quality of life, the incidence of dysplasia and cancer, the incidence of mortality. People with IBD have excess mortality as compared to the normal population, and people are now targeting the long-term outcomes of the disease. So to start with, once there's an active disease, the therapy is to be started according to the risk, and we see the symptomatic response, and we see the endoscopic response. These are called the short-term targets. So we see this कि एक कोई flare में आए, the patient has come in flare, we treat the patient in flare, we see it's his clinical response, and few months down the line we also see 3 to 6 months down the line we also see its endoscopic response. So these are the short-term targets of IBD remission. The intermediate targets would be to keep the biological markers in check, to keep the fecal calprotectin levels in check, to see if the patient is requiring any surgical procedures for its disease, be it UC or be it Crohn's disease. And the long-term targets would be then the quality of life, the mortality risk, the incidence of dysplasia, and all those. So people are now targeting the long-term effects. And here came STRIDE consensus. So this is the first major approach of the international IBD stalwarts to meet together. In 2015, they declared the STRIDE consensus, wherein before 2015, it was just clinical remission, and some studies had come for endoscopic remission. STRIDE consensus put forward these things. For treating a patient with Crohn's disease, there should be resolution of abdominal pain, and normalization of the bowel habit should be a target. So the clinical part should be a target. We have to assess the outcomes at least every 3 months until resolution. So this was a new target introduced, that every 3 months we have to assess the patient clinically, biologically, and endoscopically if required. After symptom resolution, outcomes should be assessed at least every 6 to 12 months. So it's not just that we treat a flare and the patient is not to be followed. The STRIDE consensus put forward that it has to be assessed every 6 to 12 months. For intestinal inflammation, including the ulcerative colitis disease, it has to be a treat to target. It has to be a target approach treatment. The absence of ulceration has to be a target. And endoscopy or cross-sectional imaging should be performed 6 to 9 months after the treatment starts. So this is a new addition. It is not just treating clinically. We have to introduce endoscopy to see the response in 6 to 9 months. Histological remissions and biomarkers are currently were then not recommended. So they did not recommend that you need to use the histological remission part or the biological marker CRP and fecal calprotectin for UC. Then, so this was the STRIDE consensus first part, which was published in 2015. Later down the line, so I did not include the STRIDE 2 consensus, which was recently published in 2020-21, I suppose, wherein they have added certain factors like growth of a child in childhood IBD and quality of life measures in adult IBD. So that was a STRIDE 2 consensus. So STRIDE also focused on short-term and intermediate-term targets. Later came SPIRIT consensus, which is recently published, and they are now targeting the long-term effects of IBD as a disease. So along with the goal setting is, along with having clinical remission, endoscopic remission, following up the patient to reevaluate them every 6 to 9 months, they are targeting now the change in the IBD disease behavior as a whole. So down the line, they are targeting quality of life measures like SF36 scores. They are targeting the incidence of dysplasia and the incidence of cancer and the mortality risk as a whole. So as this is the concept in a single slide, which is my last slide, and here I want to focus to start with treating IBD was just focused on treating the clinical symptoms and making the patient feel better. Later we evolved into biological markers like CRP and fecal calprotectin, and we targeted those to be better. Then we found that mucosal healing correlates good with the long-term outcomes of disease mortality and the disease symptoms. So that was incorporated, and the studies, clinical studies which are being conducted according to STRIDE consensus, focus on the endoscopic remission also. Down the line, there are other targets like histologic remission and the long-term outcomes, as stated in the SPIRIT consensus. So that's my talk. Thank you.
That was a nice elaborate talk by Pratik.
Thank you.
So all the remissions are important: clinical remission, endoscopic remission, histological and biomarker remission. Which is the most important?
Sir, these are steps to a goal.
For the patient, obviously clinical remission is more important.
Yes.
Any questions? And we can use simple criteria like criteria of true love and bits, which can be performed on bedside.
Yes, sir. This is the routine practice which we do, which we generally use clinical markers to see our patient if they are improving or not. The people who are targeting different goals, these are very clinical study oriented, because new molecules are coming in for IBD treatment, and there has to be a standardized definition of remission. So people are targeting deeper remissions now.
Will be time schedule to assess endoscopic remission?
Yes, sir. After a flare, that means after a disease activity, when patient is treated, he is clinically reviewed during the admission, and he has to be endoscopically reviewed in 6 to 9 months.
So actually, I wanted to ask more or less same question, that if the patient is under your follow-up, what are the recommendations when the endoscopy should be done to assess remission? Obviously, the patient has 5 or 6 motions. You are not going to assess for the remission. But if the patient is quiescent clinically, how often the endoscopy the colonoscopies are recommended, and should we take biopsies to assess remission? How many biopsies? Are there any guidelines about it?
Sir, the frequency of endoscopy to be done down the line has not been noted. After a flare, for which the patient is getting anti-flare treatments in the form of steroids, etc., or is requiring admissions, endoscopic evaluation and clinical evaluation is needed after 6 to 9 months. After that, nobody has told that every 6 months we have to do an endoscopy. If the patient is quiescent, we do not follow for endoscopic remission in clinical practice. However, in clinical studies, endoscopic remission is sought. Second thing, endoscopies could be done for dysplasia surveillance. That is an altogether different topic. Yeah. But for this flare, down the line, no endoscopy.
See, what I do in my practice is when the patients, they have, say, 1 motion, 2 motion, no blood, I get their calprotectin. And if the calprotectin is less than 150, probably I might continue with the same or the minimum dose of 5-ASA to prevent the next relapse or the flare. But if the calprotectin is high, of course, this is not supported, but I tend to give them maximum dose of 5-ASA with the idea to achieve remission.
Rightly said, sir. Even it is recommended to use calprotectin in follow-up. It does not, because it helps us to predict relapse, one, and to know the response of the treatment which we have given in the flare. Yes.
I use it as an indirect marker for mucosal healing. Would you recommend combination of CRP and calprotectin to be measured? Because I think
Sir,
combination is it better than single agent like calprotectin?
So studies in CD have Crohn's disease have shown an excellent relation with CRP and calprotectin. Studies in UC have unfortunately not correlated with CRP. So even in the recommendations, CRP has not come for the UC part. But for Crohn's disease, yes, CRP has to be used and it has to be kept less than 5 units.
Any studies on combination versus any idea?
I'll have to dig up, sir. I'll let you know, sure.
I also don't know.
Very practical question. Why we are heading to a goal of mucosal healing? Are our goal of clinical healing is not able to predict properly the flare, or all our gastroenterologists are feeling that yes, I am treating clinically my patients, but yes, sir, randomly patients are getting flare. So should I? Is it like you want to change your practice? Yes, nahi, since you are saying that after achieving a flare, okay, 9 months hala, you want to do we want like he should give up a surveillance of another 1 year, even if the patient is having in QC mode. Why we are heading towards that goal?
There are
Are we are not satisfied with the clinical symptoms? Suddenly they get relapse.
people were
Yeah.
satisfied with clinical
Yeah.
remissions in the 70s and the 80s.
Yeah.
Later down the line, when they followed up their patients who were clinically quiescent, they had gotten into adenocarcinomas and dysplasia. There are extensive studies now to show that clinical remission itself is not enough for predicting long-term outcome in IBD. As I showed, there is a discordant rate of around 40 to 45%, where even in our practice, as we see, people with extensive pancolitis in general, which I have seen, they hardly pass a stool or two. They don't complain of bleeding over months to years. Whatever I have seen, I can gain insights from sir and other seniors also. So definitely treating only the clinical disease might not be enough. Yeah, and I'm trying to
Complications are
interpret.
less. Complications are less. Relapses are less. And I'm not sure about mortality, but with deep remission, these chances are definitely better. The complications like stricture formation, malignancy are better once you control inflammation, because the inflammation is the initiating event for, the dysplasia and the malignancy and other things. So it is said that complications are less when you achieve deep healing. That's it.
So
In
rightly
fact-
said by
In fact, when the patient first comes to our OPD, the first revision to be fulfilled is the clinical criteria only, then the endoscopic, then the mucosal, and then the biomarker.
the first step is clinical remission. Unfortunately, that clinical quiescency does not correlate with the endoscopic remission, and inflammation is the driver for all the
That's the role of fecal culprit.
Discordant.
Yeah.
Discordancy.
discordancy.
There is a possibility that this could be only a research tool in order to study. That is what it looks like from your talk only, that most of these various types of remissions which you have described, these are probably being used as a research tool because so many other molecules are available, but they are presently not being practiced by most of the gastroenterologists. That's what you want to say.
Right.
yeah?
Yeah. And maybe after these talks and these discussions, we head towards some of them, at least the endoscopic remission part.
But they could be futuristic. Maybe
Yeah,
if you are an IBD specialist, then perhaps you could be doing that.
The complications, as I said,
Yeah.
the results and the complications and the having another episode of colitis is less if you have only clinical remission versus deep remission. So that is the goal.
And so
That's why
the recommendations for step-up therapy are now based on deep remission. Have started now based
Yeah.
on. So we cannot only rely on clinically theek hai, so we do not need a step-up. So we could be disvaluing the patient in that part. That if we are depending only on the clinical remission, and if he has an ongoing endoscopic activity, we are not allowing him to give step-up therapy. So in that sense, yes, we should head towards endoscopic remission.
good, well done.
Yeah, thank you, sir.
Next topic will be by Dr. Shrikant Mukhawar, pathogenesis of IBD and role of facetinib.
Actually, at the outset, I must have thanked Rachit for selecting these topics. I forgot to mention because the sequence went like that. So, Rachit has helped me in selecting these, making these topics for us. So, we will be discussing 6 of them now. And the second thing is, Shashank is not well, so he is not joined. So that topic will, automatically get cancelled or postponed to the next meeting. I'll be briefly discussing about the pathogenesis of IBD and role of tofacitinib. I mean, the pathogenesis of IBD is the most complex. In fact, I wanted to discuss this pathogenesis with the whole idea that where the molecules are working, one should know in IBD. So that was the idea of discussing the pathogenesis. Under the physiological condition, there occurs a good homeostasis between the commensal gut bacteria, epithelial cells that prevent the entry into the inside, and the immune cells within. And Th1 cell and Th17 cells are predominantly involved in this, and there is a balance between these organisms, the mucus layer and the lamina propria, leading to homeostasis. The homeostasis is disrupted in a susceptible host either by dietary factors, antibiotics, enteropathogens, and stress. There could be genetic factors involved in disruption. Prashant, you can join. Resulting in what? Hyperactivation of T helper cells and Th17 cells. There is increase in the tight junction permeability, leading to what is known as uncontrolled chronic inflammation. So basically, three things happen. There is something in the lumen regarding the diet, antibiotics, enteropathogens in a susceptible host who is destined to get IBD. The genetic factors results in excessive, uncontrolled, unregulated chronic inflammation leading to development of IBD. So basically it's a dysfunctional response, unpredicted response from the innate and adaptive immune system. There are multiple cytokines are overexpressed, and that will be seen. Amplification of the immune response leads to destruction of the tissue, and there occurs recruiting of the inflammatory cells leading to dysfunction, inflammation, and persistent inflammation. So this is depicted in this, that you have a leaky gut, dendritic cells being active, and the host of inflammatory cells, and the below is the capillary where they have a MADCAM1 receptor where alpha 4 beta 7, that is integrin, is attached. So this is helpful. Now you see here disruption of the tight gut, the integrin molecule being attached to the endothelium, thereby prevents trafficking of the lymphocytes to the mucosa. And the third is upregulation of inflammatory cytokines like CXCL1 and CXCL3 and 8, which leads to recruitment of circulating leukocytes and chronic inflammation. So in nutshell, you have three things: genetic factors, person is perceptible to having genes of IBD, environmental factors, and chronic inflammation, which is unregulated or dysregulated. Now we see mechanisms of various drugs. Now we have these cytokine block drugs like utsicunimab, which we were discussing right now. So you have IL-12 blocker drug, that's utsicunimab, IL-23, mircuzimab, brazikumab, gutulizumab, and rizanumab. Difficult to pronounce the names. Then there is a intracellular signaling pathway blockade, JAK inhibitors, which we are going to discuss. So they act on the intracellular compartment, that is the JAK receptors. Then we have a cytokine anti-TNF infliximab, which you all know. They are acting on the anti-TNF and cytokines, and we have three varieties in this. Then there is a lymphocyte trafficking blockade, which we already discussed, alpha 4 beta 7 vedolizumab, etrolizumab, and these anti-MARCAM molecules, and the smaller molecules, sphingomyelin 1 phosphate receptor agonist, ozanimod. These are the various places, because we discuss various drugs, but so in IBD you have so much amount of armamentarium, right from correcting the leaky gut to tackle the inflammation, extracellular inflammation, intracellular inflammation, receptor binding at the vascular site. So these all, you know what are the drugs which are available: aminosalicylates, corticosteroid, immunosuppress, and now these new drugs, JAK inhibitors. Up till now, there was probably a monopoly of anti-TNF for the management of these patients. But now we have SIP modulators, as I told you, the etrasimod, ozanimod, then IL-23 blockers, mirikizumab and these drugs. Then there are signaling inhibitors and integrin blockers, vedolizumab. Now, what is the problem with biologics? 30% they don't respond, and 20% over a time loses response. So 50% of the patients are still there, those who have moderate to severe disease, where need for new drug is required. So I think before we go on to the trial propers, I just would like to brush you up with the Mayo score. This is the most top scores in all UC trials. So one has to revise it. The stool frequency, there are 0, 1, 2, 3 points. The 0 is normal number of stools for the patient. 1 is when 1 to 2 more than his normal. 3 to 4 more than his normal is 2, and 5 or more than his normal would be decided as a score 3. Rectal bleeding, mild streaks of blood less than half, obvious blood alone only is 3. Finding an endoscopy of mild disease, erythema, moderate disease when marked erythema and erosions, severe disease when there is a spontaneous bleeding and deep ulcers, and of course the physician's global assessment, mild, moderate, severe disease. So total it's a score of 12. 6 to 12 is supposed to be moderate to severe disease. Now this is a new armamentarium for IBD. Earlier only for a decade or so it was infliximab, and infliximab. Now we have small molecules like ozanimod, etrasimod, then filgotinib. All these are JAK2 inhibitors, the upadacitinib and TD1473. So all these are small molecules. And we have a humorized antibodies, which are mirikizumab, brazikumab, guselkumab, etrolizumab, and in our center, whatever circles have been done, we have already completed trials, phase 3 trials of all these drugs at our center. Now, What is the difference between small molecules versus biologics? Tofacitinib is a small molecule. What is the difference? Molecular weight is low, so they can cross inside the cell. The action is fast. While biologics have a high molecular weight, they can act only in extracellular with slow action. Biologics are proteins, so they are expensive, unstable, immunogenic. While small molecules are hydrocarbons, easily manufactured, much cheaper and stable. The advantage with small is oral, while biologics it's parenteral, antibody formation nil. With biologics it is yes. So these are all the advantages. What are the disadvantages of small molecule? Degradation, metabolism by hepatic and renal, while proteolytic is the way. Drug-drug interaction is yes with small molecules and probably no with biologics. Now, JAK inhibition reduces production of pro-inflammatory cytokines because JAK, this tofacitinib, binds the JAK receptor and prevents the phosphorylation, thereby preventing the cellular excitation of preventing the cellular the entry of cytokines from the cytoplasm into the nucleus, and thereby the inflammation is not caused. What is the mechanism? Now, we were talking about IL-23, single IL receptors, IL-12. The JAK inhibitors, they inhibit interferon alpha, IL-2, IL-6, IL-12, IL-23. All these mediators, they go through JAK. JAK leads to activation of STAT, and that leads to transmission of the cytokines into the nucleus and propagation of inflammation. So, you have tofacitinib, which has action on JAK1 and JAK3, but also action on this TYK2 and short action on JAK2 also. So it's a pan-JAK inhibitor. Situations and efficacy of tofacitinib in ulcerative colitis. Ulcerative colitis, second line therapy of biological failure, yes. Steroid dependent and refractory colitis, yes. Extraintestinal manifestation, yes. Acute severe colitis with failure of steroids and biologics, yes. So it is acting on all the four: steroid resistant, extraintestinal, acute severe, and as a second line after biological therapy. It does not have any activity in Crohn's disease, whether it is inflammatory, stricturizing, fistulizing. So it does not have activity. This is one landmark trial of tofacitinib published in New England Journal of Medicine in 2017. This by Sanborn, and this has included, these are three major trials, double-blind, placebo-controlled trial: Octave 1, Octave 2, and Octave Sustain. Sustain is a maintenance trial, and these are two induction trials. The Octave trial used 10 milligram BD of tofacitinib versus placebo for a period of 8 weeks. Those people who responded were randomized to the maintenance trial, which is the third trial. So all these three trials we'll see how it is efficacious. Octave 1 recruited 598 patients, Octave 2 541 patients. Patients who had active, moderate to severe disease in spite of steroids, immunomodulators, and biologics were recruited in this trial. The primary endpoint was Mayo's remission. And what is the definition of remission? Mayo score of 2, no subscore of more than 1, and rectal bleeding score of 0. The secondary endpoint was a mucosal healing at 52 weeks, remission that was sustained, that means occurring at 24 and 52 weeks. So that was the secondary. Let's see what are the results. Because the clinical criteria of remission was very strong, the at the end 8 weeks period compared to placebo, there was a gain of 10.3 and 13% in both these octave trials. And similarly, in the maintenance octave sustained trial, there was a gain of 23.2%. So a significant clinical benefit in terms of clinical remission as well as clinical remission in all the 3 trials, octave 1, octave 2, and octave sustained trials. Now, mucosal healing, as has been shown by Pratik, that's a landmark. So, in terms of mucosal healing, tofacitinib 10 milligram, 5 milligram, both the doses were better as compared to placebo in octave 1, octave 2, and octave sustained trial. Whether the response, normally it is observed that if the patient is TN who has taken biologics and have not responded, these are the difficult patients to tackle with, and their response rate is generally lower than patients who are biological naive. So this octave 1, you see the TNF experience versus TNF naive. Both the patients, when you compare, the response is not significantly different, though numerically higher. So this clinical response, and this is with placebo. This is remission, healing in naive, healing with treated, remission in naive, remission in biological experience. Though the numbers is less, but biological experienced patients will also have a very good response in terms of remission and healing. So, once you have this octave 1, octave 2, octave sustain, those patients who were responded to octave 1 and octave 2 went for octave sustain, and those patients who were better on octave sustain went on for a 10 milligram BID versus 5 milligram BID octave open label trial, which is still continuing for a period of 7 years. So, tofacitinib subscore on patient diary, if you see the quality of life, that is significantly better with this drug at all the points. The safety, efficacy, and this is a 36 months data which is published in this January 2022. 3 years data of tofacitinib 66. That means about 70% of patients will have clinical response and endocardial. So roughly we can say that out of 3, 2 patients will have clinical response remission and endoscopic remission. What if the patient does not respond to 8 weeks of induction dosing with 10 milligram BID? What you can give another 8 weeks trial, which is an extended induction without losing the response and without side effects. So that's a strategy. And the some number of people would respond still after extending. So the idea of this is 8 weeks if response maintenance, 8 weeks no response, second extended induction if response maintenance. If after 4 months, if the patient doesn't respond, probably he would go out of the trial. Now, what happens in acute severe colitis? Saurabh told us that infliximab is the only drug for this. Now, you have this retrospective data which is published in 2021 Clinical Gastroenterology and Hepatology, where the dose of 10 milligram TID is given for a period of 3 days, followed by 10 milligram BID, and this dose appears to be better as compared to 10 BID and placebo, and the hazard ratio for preventing colectomy was significantly higher, 0.11. So 90% reduction in colectomy rates. We have a surgeon also here. So we 90% reduction. So this drug is also, you can be used as one of the armamentarium. The advantage is a short half-life of 3 hours. Within 3 hours, we can't give vedolizumab for acute severe colitis because the action takes 15 days. So you want a drug which should act very quick. Action within 3 days. Preoperative complications are less because of the short half-life. May be useful as a second-line therapy in acute severe colitis. Thromboprophylaxis is essential when used. Now, this drug has some of the disadvantage. There is increased risk of infections, opportunistic infection, herpes infection, increase in LDL and HDL cholesterol, thromboembolic events, teratogenicity, hematological adverse effect like bone marrow suppression, increase CK kinase, increase hepatic enzyme elevation and creatinine. So one has to monitor all these, out of which herpes infection, zoster infection is a very common infection. There is as we see, there is a drug-to-drug interaction. If we are using antifungal, reduce the tofascinate dose because otherwise it can be toxic. If you are using rifampicin, you may have to increase the dose. In hepatic renal impairment, mild disease, no dose adjustment. But if you have a moderate disease, then probably 50% reduction. Same is true about creatinine if you have creatinine, impaired creatinine. Contraindications to tofascinate, pregnancy and lactation should not be used. Screening before for tofascinate is similar to those of biologics. You have to find out about lateral infection, tuberculosis, herpes, especially chickenpox. Find out the risk of thromboembolic phenomena. You can get a bone marrow suppression, enzyme elevation. So one has to do this. And dose adjustment depending upon the. So get the patient a CBC, LFT lipids periodically as told. Monitor for drug-induced liver toxicity, thromboembolic infection, malignancy. There was a black box warning of a certain JAK inhibitors that there is an increased risk of serious heart-related events and thromboembolism. But the two papers which have been recently come 2022, February 3, have shown that tofascinate was not associated with higher risk of adverse thrombotic events compared with anti-TNF alpha. Even in the long-term open trial, except for serious infection and zoster infection, The other factors have not been corroborated in a long experience of 3 years. Same is true about the real life tofacitinib. Herpes zoster vaccine is available in India, but if you want to give live attenuated vaccine, don't give it at the same time. It has to be 1 to 2 months before. Factors to consider: if you have an extraintestinal manifestation, it's an advantage because oral drug, short half-life, no immunogenicity, clinical response. Disadvantage is probably increased risk of thromboembolism, but that too dose related. If the dose is 10 milligram BD, there is increased risk, but not with 5 milligram BD. Increased risk of infections and cost. It is as good as 5 USA, 50,000 rupees a year. On and off therapy can be given. Still, it will be effective. You can give therapy, omit therapy. Future probably maybe a combination tofacitinib with anti-TNF or vedolizumab plus. I think you have a steroid-dependent colitis. Sorry. Last couple of slides. Steroid-dependent ulcerative colitis, no response to azathioprine, then probably infliximab. All these 5 options are there. But if there is a failure, then tofacitinib is better. All these 3 options are the common which are used in our practice. Dose is 10 milligram BID. And acute severe ulcerative colitis, no response to IV steroids. Then you have infliximab and tofacitinib, cyclosporine and surgery. Dose is higher, 10 milligram TID. Take home message: tofacitinib is effective in inducing and maintaining remission. Response is reduction of Mayo score by more than 3. Mucosal healing, favorable effect on quality of life. Oral drug, less side effect. Avoid colectomy in severe acute colitis. Fast action as early as 3 days. Future may be combination therapy. Thank you.
Before starting drug, what precautions we have to take? Like EPG expert or
Yeah, I think we will have to, the infections are there, so you have to go by whatever clinical parameters with the patient has. The patient has fever, counts, procalcitonin, because many of these patients are quite sick, and then quantiferon gold for TB. All these tests have to be done, which are the protocol for biologics. That should be done. And fortunately, the risk of thromboembolism, though, was noted in patients with rheumatoid arthritis because the dose given was higher, has not been seen with ulcerative colitis. So basically, the dose is, if the dose is higher, the thromboembolic risk is higher. The dose is lower, the risk is lower. I really don't know what is the mechanism of thromboembolism, but probably some inflammatory pathways.
Sagar Patil is online and he has a question for Mukherjee sir. Can we consider tofacitinib with steroid or azathioprine in steroid dependent cases?
Tofacitinib
With steroid or azathioprine in steroid dependent cases? This is a question by Sagar Patil.
Yeah. Steroid dependent cases, most of the times what happens is the steroid doesn't work. Azathioprine reduces the dose of steroids. So that is why it is given. Now, tofacitinib with steroid combination, I feel that can be given. There is no contraindication for giving it. But whether it will reduce the dose of steroids, I mean, it will act independently. So why give steroids then? Why not tofacitinib alone? That would be my viewpoint, rather than combining it with steroids. If you have steroids, you taper it and start a drug, probably which is more efficacious, shorter acting and fast.
Compared to acute severe ulcerative colitis, steroid refractory, steroid dependent, and azathioprine refractory cases are much more. So, is this?
Azathioprine you would use for maintenance treatment, for not.
Yeah,
for
but there can be a breakthrough bleeding while a patient is on azathioprine.
I mean, you have to treat like relapse of ulcerative colitis.
So, would you consider tofacitinib in those patients where azathioprine is not working as well anymore?
I mean, it would not be taken as a molecule in place of azathioprine, but it can be taken as an alternative drug if the steroids and azathioprine is not working. That is my message. Because you see, for induction, if you say steroids, biologics, azathioprine is not for induction.
Yeah, sure.
Azathioprine will be to prevent next episode and keeping maintenance. Yeah.
Excuse me. If you can withdraw, excuse me, I'm here, Sharad.
Sir.
If you start azathioprine in a patient who is receiving steroids in order to reduce the dose of steroids, and you successfully withdraw the steroids, keeping azathioprine, you still call it as a steroid dependent? My point is that you started with steroids, and then subsequently, in order to reduce the dose of steroids, you started azathioprine. You built up the dose. After 6 weeks, you find that you are able to reduce the dose of steroids and get away or get rid of steroids. You still call it as steroid dependent?
See, definition of steroid dependent is you cannot
Cannot
you
stop.
cannot reduce the dose of steroids
Right.
below 20 milligram
Right.
to reduce the disease activity.
So this only answers this question asked by Dr. Patil, that when you are treating a patient who is steroid dependent. So you are not withdrawing steroids in these patients, and you are adding on something else. Say azathioprine or tofacitinib. This is what I guess.
What I mean is steroid dependent means any patient who continues to have symptoms in spite of dose of 20 milligram. Steroid refractory means any patient who has disease activity control, but then there is a relapse of disease activity within 3 months of stopping steroid would be defined as steroid refractory. This is what.
So this simply.
Monotherapy with 5
I think tofacitinib, no, that I may not be able to know about it. Huh?
I think it is not working. That's why you use it.
No, 5-USA.
You're generally using them if 5-SA is not working. So see, when you're using biologics, you're only using it monotherapy. You don't give 5-SA with it. So something similar conceptually, I don't think you'll have to use 5-SA because it's already failed, So it's not adding any benefit, so to speak.
So
that's my thought. I mean, I don't know if any trial has shown otherwise, but that's my feeling. Yeah.
So today, what is the best patient and common clinical situation where you will use tofacitinib?
I feel that any patient with steroid refractory or steroid dependent ulcerative colitis who is not responding, having a moderate to severe disease, active disease, this is a very, very common chunk of patients. We don't use biologics in our practice very freely because of the cost involved. So because this has a less, cost, and this can be taken as a second line drugs in a patient with moderate to severe colitis who has not responded to steroids and azathioprine combinations. That is number one. The second would be severe acute colitis not responding to steroids. I would certainly, before colectomy, would like to use this drug.
Or would be a patient who has 2 or 3 relapses in a year, and in place of azathioprine, you can add tofacitinib.
2 to 3 relapses in a year. Yeah, but you cannot. Azathioprine is a safe drug. Tofacitinib associated with chances of infections, thromboembolism. So probably you can't compare it with azathioprine because it's a safe, time-tested drug without much side effects.
When azathioprine with pancreatitis, induced pancreatitis is a better drug to start. I have experience with a patient who was steroid dependent, shifted to azathioprine, was stable. She came with abdominal pain. We evaluated her pancreatitis. We stopped the azathioprine. She get better. After that, we just added, because the symptoms started again, we have to add tofacitinib. After tofacitinib, the induction dose only her symptoms get relieved. She is on maintenance for 2 months. After that, we stop the tofacitinib also. Now she is only on ISA.
Sir, I would like to share my experience with acute severe colitis and tofacitinib. There was an incidental encounter basically. So this lady was around 50-year-old with the IUC of 5 years duration with acute relapse. It was quite severe. She was started on steroids but didn't do well for 3 days. And incidentally, she had joint pain. So she was seen by a rheumatologist. Now rheumatologists often use tofacitinib. So he started tofacitinib and surprisingly she did well after 3 days. So probably I think we can consider tofa with steroids in acute severe colitis.
Because this is not this.
Right.
Actually, to be frank, I was also not knowing till I read
Right.
this. Right.
So that was an incidental first encounter with tofa, and she's doing really well after even after 5 weeks of tofa. No, she is 50-year-old mother of 2 old children. So I think it's worth trying. The second important thing is we can continue with tofacitinib and we can continue rather than starting we can continue tofa for years. Safety issues are really good.
The 3 years data has not shown any very
Right. Second important thing, sir, regarding 5-ASA in patients with colitis. Now, we have been using, almost all of us are using 5-ASA in colitis, irrespective of whether we are giving immunosuppressants or not. One of the reasons being it prevents development of malignancy, which was shown in previous papers. So, it's because we all are together here. So, should we, I would like to know everybody's opinion, should we really give 5-ASA in patients who are doing really well with ASA for 4-5 years? Or should we consider stopping 5-ASA?
Initially, my policy was when the patient was given 5-ASA, I used to stop when the patient was given azathioprine. I used to stop 5-ASA. But then subsequently there was one paper, probably Sagar had sent in our digestive disease group only, that the combination of 5-ASA and azo is better than AZA alone. That's why from that point, maybe 4 or 5 years back, I started combining 5-ASA and azathioprine, continuing both. And of course, 5-ASA is without much side effects. So,
Is there a clear-cut guideline not to use 5-ASA when a patient is well controlled on ASA? I mean, I would, in all my 100% patients, I use ASA and 5-ASA.
like that is saying, na?
No, so is there, we all get this question raised and discussed. Many times people tell you that when you are using azathioprine and patient is doing well on azathioprine, you should not be using 5-ASA. So, I mean, if anybody is updated with the guidelines about this, that would be great.
Sir, Rachit. Sir, I don't think there is a guideline saying not to use, but I think nobody suggests if the patient is in remission with ASA, I don't think there is any additional need to use 5-ASA. As I think the last eco guidelines. That's my take. If anybody wants to add.
Clinical practice in the West, they didn't use combination. They only used azathioprine. So I don't know if alone. So nobody used. I mean, that was the clinical practice. I don't know if there are other papers like you mentioned
Saurav
that
has
there is.
worked in the center where they are IBD specialist, so probably you can tell
Yeah.
about in practice.
Yeah, at least clinically, that's what they did. Now, if it is something with newer data which has shown something else, is fine. But
Actually, my father is not there. Otherwise, I distinctly remember that he had put a paper in the our digestive disease group about this combination of. And that was in Red Journal, American Journal of Gastroenterology. We would like to review and probably clarify during our next meet.
So, can you summarize by saying that now we have a new steroid sparing agent
Yeah.
in place of azathioprine?
It's a new drug.
No, it's a steroid sparing drug instead of azathioprine. I mean,
Would not
not instead, but additional drug along with
I
azathioprine.
would not say that it's steroid sparing, because I would say that it's another molecule in your armamentarium, which is quite orally available, fast acting, and of course, effective drug. I would not be using it in place of azathioprine. I already commented that, so it will not be.
Is there any risk of lymphoma with other after prolonged use?
Yeah, all these are figures are there, but I know you feel that 1 lakh patient and 5 lymphomas.
So we can continue other for longer duration indefinitely. I mean, but
We have continued ASA for as long as 10 years. There was one trial which has come that after 5 years of azathioprine, if the disease is in remission for 5 years, you can stop. So then the patient was given an option, and I have a patient who is very well known to me. 7 years on azathioprine, no disease. She has stopped azathioprine for the last 3 years because she started getting these lipomas and neurofibromas.
More than the
She's
duration,
still better. She's still better without ASA.
more than duration of azathioprine, it's the age at which you need to stop. So, advanced age you should not be using. So, as I think beyond 65, certainly you should stop azathioprine on all patients.
I think ECO guidelines, they have mentioned 4 years safely we can give, but they have not commented about more longer duration than 4 years.
There is one study that 5 years of patient remission with azo you can probably stop.
yeah, I think the concern was for the hepatosplenic lymphoma, which tends to occur in younger individuals. I think as pointed out, I think the issue is, yes, the relative risk is maybe 1.5 or 2 times or so, but the absolute risk increase is maybe 1 in like 1 lakh or something. So this, you may find one patient out of everybody, all gastroenterologists treating in Nagpur may find one patient in 10 years. So, but yes, of course, that exists, and that's true. But then again, I guess we have to weigh between safety of TOFA versus ASA. And it's a new molecule, so let's see how it fares, you know. Safety profile really decides. I think they're all effective, so.
Thank you, Dr. Mikar. We'll move on to the next topic, therapeutic drug monitoring in IBD by Dr. Piyush Maradwar.
Good evening, respected seniors and my dear colleagues. So myself, Dr. Piyush Maradwar, working as a consultant gastroenterologist, hepatologist and endoscopist at Wockhardt Hospital, Nagpur. First of all, I would like to thank Mukhyavar sir and Midas Medical Foundation and MSN Pharma to give me this opportunity. Today I will be discussing about therapeutic drug monitoring in IBD, importance versus practicality. So what is therapeutic drug monitoring? Therapeutic drug monitoring is the clinical practice of measuring plasma drug level at designated intervals to maintain a constant plasma concentration in a patient's bloodstream, thereby optimizing individual dosage regimen. Now, it is used mainly for monitoring of the drugs with narrow therapeutic index and marked pharmacokinetic variability, medications for which target concentrations are difficult to monitor, and for drugs known to cause therapeutic and adverse effects. Now, the goal of therapeutic drug monitoring in case of patients with inflammatory bowel disease, today's talk, is to evaluate the plasma drug concentrations while detecting the presence of anti-drug antibodies during the treatment timeline to tailor the drug dose accordingly. Now, before moving forward, first, what are the causes of drug failure? Now, mechanistic failure occurs when the patient is not responding despite optimal drug trough concentration. Trough concentration is a concentration of drug in the plasma just immediately before the next dose. Now, this type of failure is likely related to the disease process being driven by inflammatory mediators that are not blocked by the particular drug. So, therefore, these patients are unlikely to respond to other drugs within the same class. Now, non-immune mediated pharmacokinetic failure. This occurs when patients do not adequately respond to therapy in the setting of subtherapeutic trough concentrations and absence of anti-drug antibodies. That is why it is called non-immune. So this phenomenon results from rapid drug clearance. So often in the setting of high inflammatory burden. So now immune-mediated pharmacokinetic failure. This occurs when patients who have low or undetectable trough concentrations and high titers of anti-drug antibodies. So we will have to change the drug in this immune-mediated pharmacokinetic failure. Now, need for therapeutic drug monitoring in inflammatory bowel disease patients. Now, biologic agents such as infliximab, adalimumab, certolizumab, vedolizumab, etc. have revolutionized the treatment of patients with inflammatory bowel disease. We have seen in the talks. Now, nevertheless, around 30% of patients, as Mukiwar sir has mentioned, they are primary non-responders, and 30 to 40%, that means almost 20% more patients showing initial clinical benefit have secondary loss of response. Now, numerous studies suggest that higher serum drug concentrations are associated with a higher rate of favorable therapeutic outcome, including clinical, biochemical, biochemical means C-reactive protein or fecal calprotectin, and endoscopic, histologic, and composite remission. Already Pratik has discussed this. Now, therefore, in order to achieve specific outcomes such as mucosal healing, high drug concentrations are required in comparison to the clinical response or remission achieved. So what is our target? Depending on that, trough concentration varies. So trough concentrations required will be more if we are targeting the mucosal healing or deep healing, deep remission. Then on the other hand, anti-drug antibodies and undetectable or low drug concentrations have been associated with treatment failure and drug discontinuation. Now, reactive therapeutic drug monitoring. So, reactive TDM versus proactive TDM, we will discuss later. It is a cost-effective strategy for empirical infliximab dosing recommended in individuals with inflammatory bowel disease to overcome the loss of response to biologicals. So now, what are the advantages of this reactive therapeutic drug monitoring? It can explain the secondary loss of response SLR to anti-TNF therapy in IBD. Now, it can identify the patients who will respond to more drugs, dose escalation, and also it can help to know which can benefit from other therapies. Now, proactive therapeutic drug monitoring. So, patient is doing fine, but still we want to check the blood levels of that drug, plasma levels of that drug. So, aim of this proactive therapeutic drug monitoring will be to improve the response rates in IBD patients and to prevent the secondary loss of response. So, this proactive therapeutic drug monitoring, we want to prevent the secondary loss of response to the drug. Although the landmark TAXIT, that is trough level adapted infliximab treatment RCT, failed to meet its primary outcome due to some methodological issues, it demonstrated that proactive therapeutic drug monitoring of infliximab was associated with a lower frequency of undetectable drug concentrations and a lower risk of relapse compared to clinically based dosing. Now, proactive versus reactive therapeutic drug monitoring. in patients with Crohn's disease, along with low infliximab concentration, one-time dose optimization improved clinical remission rates and CRP levels. Now, proactive therapeutic drug monitoring compared to reactive therapeutic drug monitoring of infliximab was associated with less treatment failure and need for IBD-related surgery or hospitalization, risk of antibody towards infliximab and serious infusion reactions were found. Though this data was not with randomized trials. Now, a study demonstrated that in patients who underwent reactive therapeutic drug monitoring, subsequent proactive therapeutic drug monitoring of infliximab was associated with greater drug persistence and fewer IBD-related hospitalization than reactive therapeutic drug monitoring alone. And multi-center retrospective study showed that at least one proactive therapeutic drug monitoring of adalimumab was independently associated with a reduced risk for treatment failure when compared with standard care. Now, how practical is therapeutic drug monitoring? Now, importance we have seen. Now, practical difficulties with therapeutic drug monitoring of thiopurines, this TPMT testing. It can identify patients with low or absent enzyme activity. Therefore, it has the potential to avoid myelosuppression. However, TPMT assay is not routinely performed in many clinics due to cost and maybe genetics also. There is a genetic difference between American population and Indian population. And furthermore, most thiopurine-related hematologic adverse events occur despite normal TPMT status. TPMT testing cannot substitute routine complete blood count and liver enzyme estimation despite the normal TPMT status. Also, TPMT testing does not impact the burden of the routine monitoring that is mandatory for all thiopurine treated patients regardless of the TPMT status. Now, practical difficulties with therapeutic drug monitoring in IBD patients. Target trough concentrations have been established for infliximab, adalimumab, and certolizumab pegol maintenance treatment, but the data for infliximab are more robust than those for adalimumab. So there is also insufficient evidence to establish target lower limits for golimumab, vedolizumab, and ustekinumab, and optimal trough concentrations for induction therapy are uncertain. This is only for maintenance therapy. Now, the target trough concentrations must not be treated as absolute values, since they can vary based on several factors such as target endpoints, whether our target is clinical remission versus mucosal healing, or disease severity, whether it is high activity is there or low activity of disease, whether phase of therapy is induction or maintenance. Depending on that, the trough concentration varies. Now, furthermore, a small proportion of patients may not be in remission at the recommended target plasma concentration. Now, thereby a higher concentration may be required. Therefore, the application of target trough plasma concentration in practice is not straightforward for biologicals in inflammatory bowel disease. And lack of standard guidance for interpretation of results and a lack of standardization among commercially available assays. This also have practical challenges for therapeutic drug monitoring of biologicals. So drug interference can influence the measurement of serum concentration of biological agents and anti-drug antibodies levels, which can result in poor specificity, sensitivity, and reproducibility. For example, commercially available ELISA detected false positive infliximab levels in 18% of tested population in a study. So other drugs, they can be falsely detected as infliximab, so it is not very reliable. It is not standardized basically, and there is uncertainty in the upper and lower limits for high titer and low titer of anti-drug antibody levels measured with available assays. Higher titer may come with limited benefit in dose escalation, hence switching to a different agent in the same drug class may be of greater benefit. Now, the need to measure plasma trough concentration require assessment immediately before dosing. So, which means that patient with the non-response or loss of response may have to wait until the next treatment for dose escalation with a reactive therapeutic drug monitoring approach. So he will have to wait till the results comes and again he will have to come back. The patient also must undergo additional blood testing and follow-up. So in addition to the practical burden there may also be a financial burden, which is very important for our patients. While therapeutic drug monitoring may benefit some patients, the costs are not yet well defined and may exceed or be less than the cost without therapeutic drug monitoring. But it can prevent patients' admission if we do that. So really, it is not actually, trial is not done. So whether it is cost effective or not. A recent meta-analysis of 9 studies of infliximab maintenance therapy in adults with inflammatory bowel disease found that although therapeutic drug monitoring was not associated with superior clinical remission rates, there was a cost benefit. Further research is needed to assess the cost of therapeutic drug monitoring for drugs other than infliximab. So what guidelines says about therapeutic drug monitoring in inflammatory bowel disease? So in adults with active inflammatory bowel disease treated with anti-TNF agents, AGA guidelines, they suggest reactive therapeutic drug monitoring to guide treatment changes. This is conditional recommendation. That means majority of the clinicians feel that, but many clinicians that they are against that also. So, but this is conditional recommendation by AGA. Then in adult patients with quiescent IBD treated with anti-TNF agents, the AGA makes no recommendation regarding the use of routine proactive therapeutic drug monitoring. So proactive monitoring, they are not recommending. Then in adult patients with IBD being started on thiopurines, the AGA suggests routine TPMT testing. So either enzymatic activity or genotype to guide thiopurine dosing. In adult patients treated with thiopurines with active inflammatory bowel disease or adverse effects thought to be due to thiopurine toxicity, the AGA suggests reactive thiopurine metabolite monitoring to guide treatment changes. Now, in adult patients with quiescent IBD treated with thiopurines, the AGA suggests against routine thiopurine metabolite monitoring. So routine is not recommended, but yes, reactive we can monitor for drug toxicity. And the ECO guidelines do not make any recommendations for or against reactive or proactive therapeutic drug monitoring in Crohn's disease patients on anti-TNF due to insufficient evidence. They are not recommending, they are not commenting about or recommending about or for or against reactive or proactive therapeutic drug monitoring. Now, in summary, this therapeutic drug monitoring is increasingly being used by gastroenterologists treating patients with inflammatory bowel disease to inform decisions about changes to treatment required due to non-response or loss of response. Now, reactive and proactive are the two main types of therapeutic drug monitoring performed for titrating the dosing of drugs in management of inflammatory bowel disease. So, for thiopurines, differences in patient responses can be accounted for by variation in their levels of TPMT, an enzyme involved in the metabolism of the drug. For biologic agents, non-response and loss of response can occur due to reductions in drug trough concentrations, which is often because of presence of anti-drug antibodies. However, despite the availability of official recommendation on therapeutic drug monitoring, there is a still lack of consensus on the how and when it should be implemented in practice and what impacts it has done on clinical outcomes. Now, alternatively, therapies that avoid the need for therapeutic drug monitoring have the potential to reduce extensive monitoring. For example, this tofacitinib. Thank you.
Excellent and crisp talk, Piyush. Any questions from the audience? Yeah.
Piyush, hi, very nice. Thank you for the talk. See, I have a question. First thing related to TPMT testing. So, do you have any data? Is there any data on TPMT and the level of enzyme activity in the Indian population? And, what sort of options are there? Because in the West, they do it routinely before starting. What's the scenario in India? That's first question. And the second question is regarding the drug monitoring. Is it, number one, available in India? Drug assays are the labs. Okay, so infliximab assay, is it even available if we have to do it in any patient? In India, any lab does it? Are you aware of that? I'm just curious to know.
Saurabh, infliximab levels and antibodies you can send to Hinduja Hospital.
Oh, Hinduja is doing it. Okay.
And Ranbaxy, if they are doing, I don't know, but Hinduja, they definitely did.
Okay.
Yeah. They did.
regarding the TPMT testing, I think India, what is your experience at TPMT testing? Do you do?
Do you have any baseline data about the mutations? How much mutations do occur?
No, in India it is not that common as Americans.
Exactly. In for first 10 years of my practice, I was doing TPMT testing for all patients. I always find the normal variant, never the.
It may not be necessary, but for medical legal purpose, you may have to do.
Sometimes the drug monitoring is also required to check the compliance of the patient, like the neurologist used in cases of epilepsy monitoring, to check the compliance also.
Yes. What is suppose you are using infliximab for 1 year, what is the prevalence of or the incidence of antibodies in general to the patients? Any idea about it?
Prevalence,
Antibodies to anti-TNF agents in general, any statistics which is available?
we use with other steroids and other therapy.
It is less.
And
In general, without azathioprine, if it is used, what is
it is almost 20 to 30%.
20 to 30%, which is a very high number.
So, in our clinical practice, if I tell you that therapeutic drug monitoring is now available, which would be the correct patient you would recommend? Is it will be the primary non-responder or the secondary failure?
Sir, secondary failures. So, primary non-responder, we will change the drug.
Okay.
Because their mechanistic failure is there. And if they are secondary failure, secondary loss of response, that is time we should do therapeutic drug monitoring.
So you do both trough levels as well as antibody levels.
Yes, sir.
And what is the strategy? If the trough levels are low, what is the strategy? If antibodies are high, what is the strategy?
Sir, if trough levels are low, that means it is non-immune mediated our loss of secondary loss of response. So we should increase the dose. And if it is antibody is there, high levels of antibodies, then I think we should change to other anti-TNF. And if
Any other question from the audience on this topic? Okay, we can move on to the.
Due to some thank you, Dr. Piyush. Due to some unavoidable circumstances, Dr. Shashank Vanjari is not able to join. So we will shift his topic in the next meeting. The last is by Dr. Rachit Agrawal, vaccination in IBD.
Thank you, chairpersons and sir, for allowing me to speak on this topic regarding vaccination in IBD. I believe it's a very important topic, primarily for two reasons. Number one, all the IBD patients have a degree of immunosuppression due to either their innate immunity or due to the drugs they are using. And secondly, regarding the vaccination, the knowledge is very limited, and I think there is a big lacuna regarding the understanding as to what vaccinations can be given and which diseases can be prevented. So to start off with, we do know that there is greater infection risk in IBD, and due to an impaired innate immune response and due to use of immunosuppressants with biologics, smaller molecules, steroids. The question is, how common are these various infections? Some diseases have been well studied, particularly influenza. So this was a study of cases and controls of about 1.4 lakhs. Anyways, so we can see in the first graph between the cases and the controls, the ulcerative colitis patients, the black represents infections in inflammatory bowel disease. So there are more in ulcerative colitis, Crohn's disease, and also all the IBD combined, and the odds ratio is 1.54. They also found out the complications in IBD versus controls. That is, the risk of pneumonia was more in the cases as compared to controls, but the p-value was not significant, although it was statistically higher. But when you talk about hospitalization, there was a significant p-value for the same. This study regarding the pneumonia risk in IBD due to all infections, there were Crohn's disease patients were 50,000, similar for UC. Unspecified IBD were about 1,000, and there were 4.3 lakh controls. The findings were similar across all three, that the infections were more in inflammatory bowel disease as compared to the normal controls. The hazard ratio for Crohn's disease was 1.71, for ulcerative colitis was 1.41, and for IBD combined it was 1.54. Coming to the next most common, that is herpes zoster. The findings were similar. It was actually the same Long et al. And they found that the hazard ratio for risk of infection inflammatory bowel disease was 1.54 as compared to the controls. So this does establish that there is more infection. And in 2016 in clinical gastroenterology and hepatology, there was this meta-analysis which had 49 RCTs, and they took in about 15,000 IBD patients. And they reported that the elevated risk for any infection had a odds ratio value of 1.19. And for opportunistic infection in particular, the odds ratio was much higher, that was 1.9. So after the establishment of infections is definitely there in IBD, we would like to look at what is the impact of treatment or the therapy on the infection. So this was a study published in 2018 where the IBD cohort was 1.9 lakh, and they found the infections were about 9,000. Seeing the number of body diagrams, so thiopurine monotherapy was less, more was anti-TNF, and the maximum was on combination therapy. Between thiopurine monotherapy and anti-TNF monotherapy, hazard ratio was 1.71, which increased further when there was combination therapy to 1.73. So coming to the next point, what is the existing status of vaccination? So this was a very interesting study in 2012. This was a questionnaire given to 43 gastroenterologists and 167 IBD patients. They found out that only 14.3 gastroenterologists reported taking an immunization history. 5.4% of the patients recalled being taking the immunization history. Going further down, 0.6% recalled being asked for a detailed history, and 42% of the gastroenterologists did not know which specific immunization should be avoided for immunosuppressed patients. Frankly, I would be in this group prior to making this seminar also. So I think this would help us. In the West, actually, middle part is also sometimes gets boring. So somewhere in the middle. So in the West, actually, it is the dual role of the gastroenterologist as well as the primary care physician. But I think in India, it's the IBD patient would follow up with the gastroenterologist. So the onus does fall on us to understand it and to execute what is required. So we'll go briefly on what are the adult vaccines available. So broadly classified into live and inactivated vaccines. In India, we have an influenza nasal vaccine. The nasal one is live. You have a varicella, you have a zoster and MMR. There's a query regarding what's varicella and zoster. Varicella is primary chickenpox infection, whereas a zoster infection is a latent reactivation of the same virus. Among the inactivated vaccines, we have an influenza injectable, DTP, pneumococcal, two type vaccines are there. One is a pneumococcal conjugate vaccine, PCV, and a pneumococcal polysaccharide vaccine. Then meningococcal hepatitis A and B and human papilloma virus are the inactivated vaccines. What are the general recommendations for vaccine administration? So ideally, I think this is an important slide which tells us when you should vaccinate. Ideally, the vaccination program in the patients with IBD should be initiated at the diagnosis of the disease or before any immunosuppressive therapy started, preferably 4 weeks before the onset of any immunosuppressive therapy. Although this is an ideal scenario, a practical scenario would be very difficult because patient does present to us whenever he has clinical exacerbation of the symptom, either the first time or on a follow-up. in IBD patients who are not on immunosuppression or without immunosuppressive therapy, there are no specific contraindication for vaccines with either the inactivated or live vaccine. So if a patient is not on immunosuppression, both live and inactivated vaccines are to be administered. If immunotherapy has been started, live vaccines are to be used with utmost caution. About 3 to 4 years ago, there was an article in American Journal of Gastroenterology 2017. They said they're not to be used, but I think in the last 3 years or so, by 2020, this article reflects that they can be used, but with caution. How exactly and what cautions are to be used is not very clear, but in general understanding, when the patient is at the lowest point of immunosuppression possible, according to the clinician, if you want to administer the live vaccine, that may be an optimum time. So this is the same. And another important point, due to a higher efficacy, vaccine should be administered during remission of the disease. That will give us a higher response. So these are the list of the inactivated vaccine that are to be used. One is a Clostridium DPT vaccine in simple. The question is, another question that arises, what is the target population, as some vaccines are specific, and whether any monitoring has to be done or a serology titer has to be done, whether the patient is already immunized or not, because a lot of people would be vaccinated in childhood. This is basically for an adult immunization. So for DPT, the target population is all patients. You need not check the immunization titer. A single dose of DTP is recommended at age 11 through 64 years, and a diphtheria and tetanus booster to be given every 10 years. For hepatitis A and B, yes, you do check the immunization titers, and we know the dosing for that. Additionally, for hepatitis B, since a lot of research has happened in immunosuppressive, even other diseases like alcoholic hepatitis, where we know that the level of immunization or antibody titers may not be optimal level. Like in CKD patients, some people have recommended double dosing. Some have recommended even 0, 1, and 2 at 0, 1, and 2 months. The ideal point is after your vaccination schedule has been completed, 1 or 2 months after that, you check for the antibody titers. And if they're inadequate, you either give a booster dose or you can repeat the full vaccination schedule. Human papilloma virus, high risk for cervical and anal cancers, to be given to both male and female, as it can be transmitted from the male to the female partner. Influenza vaccine, importantly, the injectable vaccine has to be administered, commonly known as quadriflu, which has 4 strains. There is a trivalent strain also, and it has to be given annually. Neisseria meningitis is to be given in a high-risk population group, and this is usually young males between 20 to 30 years of age who have a high risk of infection. And we have streptococcus pneumonia. I'll just come to the pneumococcal vaccine, because since pneumonia is a very important aspect in IBD. So pneumococcal vaccine has 2 parts. 2 vaccines are available. One is a PCV13, that is a pneumococcal conjugate vaccine. And the second is PPSV23, that is a pneumococcal polysaccharide vaccine. The immunogenicity of a pneumococcal conjugate vaccine is higher because in that, to a polysaccharide molecule, it is tethered or conjugated to a protein, due to which the immunogenicity is higher, whereas PPSV23, it is only the polysaccharide component. So in some countries, they advocate only pneumococcal conjugate, but as per existing recommendation, 1 dose of PCV13 at baseline, 1 year later by polysaccharide, and 5 years later by another polysaccharide booster dose. COVID-19 vaccination, I think it has been well debated over the last 2 years. And just a short slide that yes, it has to be, everybody has to be vaccinated. Bottom line, whichever is available, please do vaccinate. Coming to live vaccines, which are a little tricky because patient is immunosuppressed and there may be risk of activation. So in general, if the patient is on immunosuppression, it is still recommended you can use with caution, but I believe that everybody would be a little skeptical in using them. For measles, mumps, and rubella, before vaccination, you do check for the immunization titers. 2 doses are to be given, and if the patient is on immunosuppressive treatment, MMR is not to be given. When you talk about varicella, you also check the titers before immunization. For herpes zoster, the indication is only for patients above 50 years of age. And herpes zoster, a live attenuated vaccine is there, but sir has recently, I'll just come to that. So zoster is 2 vaccines are there. One is a live attenuated, not to be given, but a newer inactivated Shingrix, which is not yet available in India. 2 doses are to be given, and once it is available, I think you can give. Additionally, sir also mentioned that live attenuated vaccine, that tofacitinib, has a very high risk of zoster activation, so it is not to be given. One another concept which is usually very foreign to our mind is household vaccination. Like for hepatitis B, we do screen for hepatitis, family members of hepatitis B. I think household vaccination for IBD patients is very important. And the close contact should be checked and they should be vaccinated, particularly the live ones, that is MMR and influenza. Basically, the bottom line is the cocoon strategy, that it is likely that your patient is on immunosuppressant and you may not be able to give him the live vaccine. Though vaccinating the surrounding individuals may protect the individual from serious infections. Additionally, transmission from an immunocompetent vaccinated person to an immunosuppressed person has not been demonstrated for an MMR or herpes, so they can be given the household members. But if the person is known to have varicella skin lesion, then in that case, the vaccinated person should avoid close contact with the immunosuppressed person. So to summarize, IBD state is related to an increased risk of infection and more common with the use of combination therapy than monotherapy and biologicals more than immunomodulators. Ideally, vaccination is to be initiated before immunosuppression. Live vaccines are to be used with caution and only when low immunosuppression is ongoing. Regarding low immunosuppression, there is some data available. Low immunosuppression is when either your steroid dose is less than 20 milligram per day for less than 2 weeks, or azathioprine is less than 3 milligram per kg, and everything else, including biologicals, come into high immunosuppression. Annual vaccination and influenza is very important. Herpes zoster inactivated vaccine is preferred, and vaccinating household contacts is important. Thank you.
That was a nice lecture by Dr. Zichi. Any questions from the house?
My simple question is that if you have diagnosed a patient who has IBD, which vaccinations would you like to give him? And he's an adult. Before immunosuppression is started, before the steroids are started.
All the vaccines that I've said now. So all the live vaccines and all the inactivated vaccines.
So you will give him TD, you will give him influenza vaccine,
TDP,
and
influenza, HIV, HPV.
you will give him TD, not TDP.
So for the first time TDP, then a booster of DT every 10 years.
Okay. And then pneumococcal vaccine if the patient has not taken it.
Yes.
Zoster vaccine.
Right, sir. And MMR vaccine.
And hepatitis. So if he has not been vaccinated, then you would like to give it. Frequency repeat of these vaccines.
So like influenza will be annually. TT booster would be every 10 years. Pneumococcal vaccine booster would be after 5 years. Hepatitis A and B, in general, we don't know what is the response of that, but maybe if it is a healthcare worker, then maybe you check regularly.
Should we give a vaccine? Because that's a big question. Yeah, it will be different.
For Indian population.
He is already immunized with TD.
So the point is for hepatitis A vaccine, before giving, you check the antibody titer, that is recommended. Regarding DT, sir, I don't have Indian data and maybe I don't have much experience also, very frankly, regarding that. So,
Rachit, so when we started our protocols for us liver patients, cirrhotics, so we decided to look at vaccinations, and we have it almost standardized for all patients now, where every patient gets a hepatitis B vaccine, gets a, of course, non-hepatitis B patient, and a pneumonia vaccine, at least one shot. The hepatitis A, we initially had it in our protocol. Then we said, all right, we're going to get the titers. And actually, most of the patients seem to have titers positive. So I think I almost took it out of our protocol right now. So right now, I don't even bother. And that's been the experience anecdotally, but just to share, yeah.
Things would definitely change. And obviously, most of the data is still Western. I think evolving concept in IBD and vaccination, I think a lot of research can actually be done as to simply that what is the HIV titers in IBD patients.
Sir asked in an adult patient, if he has already taken all vaccination in childhood, he required again vaccination.
Yes, sir. So, except for MMR, varicella, and hepatitis A and B, where you check the titers, for IBD patients, yes, they would be required.
Rajit, my question is in prolongation with Dr. Deshmukh, sir. In I forgotten the question. I will hand over the questions to the audience. Then, if I recollect, I will ask you.
Sir.
Suppose a patient of IBD has a hepatitis B positive.
Sir.
You want to give immunosuppressant.
Sir.
And oral antivirals for him?
Sir, yes. So the recommendation, normally when we would give immunosuppression, ideally would be 1 milligram per kg body weight. That would be high dose immunosuppression, and definitely that patient will require antivirals.
Like a patient of malignancy, we advise antivirals.
Yeah. So in for IBD, the recommendation before starting immunosuppression is patient should have a surface antigen and a core antibody before starting immunosuppression. And if antigen is found to be positive, and we are planning for a high dose immunosuppression, which should be either a biologic or a prednisolone more than 1 milligram per kg, 20 milligram for more than 2 weeks. In that case, we will have to start him on anti-hepatitis B.
Rajit, is vaccination required in monotherapy with IASA in patients with IBD?
Yes, sir.
Considering the fact that they are
Sir, it is not the
partially immunosuppressed.
No, sir, irrespective if the patient is going to be on 5-ASA or is not going to be on any therapy at all, patient would still require
Patient on
immunization.
infliximab, other tofacitinib,
yes, sir.
it
It's
will
very-
require immunization.
Yes, sir.
But if he is on only monotherapy with 5-ASA, will he require?
That's what I'm saying. Sir, if he is only on 5-ASA or even if he is not on 5-ASA, is not requiring 5-ASA, but IBD is there, then because of his genetic poor innate immunity response is likely to have the infections like influenza, so he should be vaccinated. At least that is according to the data. Understand from a practical point of view, 5-ASA patients would be in very low grade immune level, and the vaccination, if we talk about all of them, would be roughly around 20 to 30,000. So that would also be an additional burden which we would need to think about.
But I think this was a wonderful talk. Quite an eye-opening new concept, and which you are not following. I mean, the data does suggest, even in Western countries, that this needs to be emphasized. So I think, Rachit, you really taught us, and definitely we should add this as one of the armamentarian in our practice, that IBD patients should all be vaccinated.
Thank you, sir. Thank you, sir.
Adult vaccination program is very, very grossly underused in India.
One online question, Rachit. One question from Dr. Abhi Deshmukh. Can we consider azathioprine tofa as a immunosuppressant and give a vaccine according to that?
Sir, as I understood from today's talk, that tofacitinib, I think, would fall in high dose immunosuppression. So live vaccines would be avoided, but you can give killed or inactivated vaccines. They should.
I think they should be given, as per the recommendation, 4 weeks prior to starting treatment, unless the vaccine is recombinant vaccine. If it is done by not live attenuated, but if it is a recombinant vaccine, then it can be given. But the problem is herpes zoster recombinant vaccine, which is available in the rest of the world, is not available in India. So, I mean, as a IBD person is diagnosed, you can't say that now you want to start tofa and the 4 weeks before. So practicality means, I think if you have a moderate to severe disease, the practicality is you vaccinate.
Although, just a food for thought, although it's not recommended anywhere, what I was thinking was that a lot of patients come to us with flare, exacerbation, moderate or severe disease. Let them settle down in maybe 2 months, 4 months, 6 months, and then definitely at that point of time would be a good point to consider if there is a protocol of proforma, so we know that which of them are vaccinated and which are not, and which have an impending vaccination schedule which needs to be completed. Thank you.
I think we come to the last session. Thank you, notes.
Yes. It was a very fantastic session. We all learned in few bits and pieces what are the importance of IBD. This was the part 1. We are shortly awaiting for part 2 session in, I think, last week of March. So we thanks Midas Medical Foundation and MSN Lab for organizing this meet. And also, sir, thank our chairperson, Dr. Prashant Bhandakar, sir, Dr. Ali Dombe, sir, Dr. Amit Gullane, sir, and also our very enthusiastic presenters, Dr. Saurabh, Dr. Pratik, Dr. Shrikant Mukhya, sir, Dr. Piyush, and Dr. Rachit. And now we can officially we can join for cocktails and dinner, sir. Yeah, thank you.
Thank you for allowing us to chair us the session. Thank you.